Hello friends, today we are going to discuss the question which was asked in DRNB critical care exam, that is on meningoencephalitis in October 2023 on meningoencephalitis. So the question was etiology, diagnostic workup and the management. The initial approach in adult presenting with the community acquired bacterial meningitis, the sensitivity of the classical triad of fever, neck stiffness, and altered mental status is low, but almost all such a patient present with at least two or four symptoms, that is, headache, fever, neck stiffness, and altered mental status. The lumbar puncture is mandatory in any patient in whom bacterial meningitis is suspected, although procedure can be hazardous. Report have emphasized the risk of brain herniation as the complication of diagnostic lumbar puncture in patients with meningitis. Once there is suspicion of acute bacterial meningitis, blood sample must be obtained for culture and lumbar puncture is performed immediately to determine whether CSF formula is consistent with the clinical diagnosis. In some patients, the clinician may not emergently perform diagnostic lumbar puncture even when diagnosis of bacterial meningitis is considered to be likely, or the clinician may be concerned that clinical presentation is consistent with the CNS mass lesion or another cause of increased intracranial pressure and will thus order CT scan of the head prior to the lumbar puncture. In those patients in whom lumbar puncture is delayed or CT scan is performed, however, there may be significant interval between establishing diagnosis of bacterial meningitis and initiating appropriate therapy. In this patient, the blood samples must be obtained for culture and appropriate antimicrobial and adjunctive therapy given prior to the lumbar puncture or before the patient is sent for CT. Delay in the initiation of therapy introduces the potential for increased morbidity and mortality, and if the patient does not indeed have bacterial meningitis. The choice of empirical antimicrobial therapy in this situation should be governed by the patient's age and by the various conditions that may have predisposed the patient to meningitis. Although the yield of CSF culture and CSF gram stain may be diminished by antimicrobial therapy given prior to lumbar puncture, pre-treatment blood culture and CSF finding like elevated WBC count, diminished glucose concentration, elevated protein concentration will likely provide evidence for or against diagnosis of bacterial meningitis. Once CSF analysis is performed for patient with positive CSF gram stain result, targeted antimicrobial therapy can be initiated in adult with bacterial meningitis. Which patient with the suspected bacterial meningitis should undergo CT of the head prior to lumbar puncture? Complications associated with lumbar punctures are variable, ranging from mild alteration in comfort to life-threatening brain herniation, which may occur in patients with elevated intracranial pressure. After lumbar puncture, there is normally mild and transient lowering of the lumbar CSF pressure as a result of removal of the CSF and continued leakage of the CSF from opening made in the arachnoid membrane that is rapidly communicated throughout the subarachnoid space. In patients with intracranial and space occupying lesion, there is relative pressure gradient with downward displacement of the cerebrum and brainstem that may be increased by lumbar puncture and thereby precipitating brain herniation. The actual risk of serious complication after lumbar puncture is presence or in presence of papilledema is less than 1.2%. So recommended criteria for adult patient with suspected bacterial meningitis who should undergo CT prior to lumbar puncture. That is immunocompromised state, history of CNS disease, new onset seizure, papilledema, abnormal level of consciousness, and focal neurologic deficit. So, what specific CSF diagnostic test should be used to determine the bacterial etiology of meningitis? So, in the bacteria, the cell counts are more than 1000. If it is viral, then cell counts are less than 1000. If it is tuberculous also, then also cell counts are less than 1000. So in cytology, in bacterial, there are granulocytes In viral, it will be lymphocytic predominant. In tuberculous, there will be mixed picture. Then CSF serum glucose index will be decrease in bacterial, normal in viral, and tuberculous it is moderately decreased. Then lactate it will be in bacterial it is more than 3.5. In viral it is less than 3.5. Tuberculous it is more than 3.5. Total protein is more than 100 in bacterial, viral less than 100, and tuberculous more than 100. So bacterial CSF barrier, it is severely disrupted in bacterial, normal in viral, and also in tuberculous it is severely disrupted. Then intrathecal Ig synthesis, in bacterial it is IgA, IgG, in viral it is IgG, and in tuberculous it is Ig. So diagnosis of bacterial meningitis rests on the CSF examination performed after lumbar puncture. Opening pressure is generally in the range of 200 to 500, although values may be lower in neonate, infant, and children with acute bacterial meningitis. The CSF appearance may be cloudy depending on the presence of significant concentration of WBC, RBC, bacteria, or protein. In untreated bacterial meningitis, the WBC count is elevated, usually in the range of 1000 to 5000 cells per minute, mm per cube, although this range can be quite broad. Bacterial meningitis usually lead to neutrophil predominance in the CSF, typically between 80% to 90%. 10% of the patient with acute bacterial meningitis present with the lymphocyte predominance in the CSF. The CSF glucose concentration is 40 mg in approximately 50 to 60% of patients, and the ratio of CSF to serum glucose of 0.4 was 80% sensitive and 98% specific for diagnosis of bacterial meningitis in children with 12 months of age. Because the ratio of CSF to serum glucose is higher in term neonates, the ratio of 0.6 is considered to be abnormal in this patient group. The CSF protein concentration is elevated in virtually all patients with bacterial meningitis. The result of CSF culture are positive in 70% to 85% of patients who have not received prior antimicrobial therapy, but culture may take up to 48 hours for organism detection. Therefore, several rapid diagnostic tests should be considered to determine bacterial etiology of meningitis. Gram stain examination of the CSF permit rapid, accurate identification of positive organism in 60% to 90% of patients with community acquired bacterial meningitis, and it has specificity of 97%. Now about latex agglutination. Several rapid diagnostic tests have been developed to aid in the etiological diagnosis of bacterial meningitis. These tests utilize the serum containing bacterial antibodies or commercially available antisera directed against the capsular polysaccharide of meningeal pathogen. The available tests include counter immunoelectrophoresis, coagulation, and latex agglutination. So, latex agglutination is the simple to perform, does not require special equipment, and is rapid. So latex agglutination may be most useful for the patient who has been pre-treated with antimicrobial therapy and whose gram stain and CSF culture results are negative. Then PCR has been utilized to amplify DNA from the patient with meningitis caused by common meningeal pathogen. That is Neisseria meningitis, Streptococcus pneumoniae, H. influenzae type B, Streptococcus agalacti, and Listeria monocytogenes. The test characteristic for the broad-based PCR demonstrated sensitivity of 100% and specificity of 98%, positive predictive value of 98.2, and negative predictive value of 100%. Therefore, broad-based PCR may be useful for excluding diagnosis of bacterial meningitis, with the potential for influencing decision to initiate or discontinue antimicrobial therapy. Although PCR technique appear to be promising for etiologic diagnosis of bacterial meningitis, further refinement of available technique may lead to their use in patients with bacterial meningitis for whom CSF gram stain result is negative. Lab test useful in distinguishing bacterial from viral. Elevated CSF lactate concentration may be useful in differentiating bacterial from non-bacterial meningitis in patients who have not received prior antimicrobial therapy. In one study of 78 patients with acute meningitis, in which CSF lactate concentration of 40 were considered to be positive discriminative factor for bacterial meningitis, and the sensitivity of the test was 96%. The specificity was 100%, and the positive predictive value was 100%. Negative predictive value was 97%. However, despite the high sensitivity and positive predictive value of CSF lactate concentration in the diagnosis of bacterial meningitis, the results are generally non-specific and provide little additional diagnostic information. Furthermore, the other factors like cerebral hypoxia, ischemia, anaerobic glycolysis, vascular compromise, and metabolism of CSF leukocyte also may elevate CSF lactate concentration. Therefore, measurement of CSF lactate concentration is not recommended for patients with suspected community-acquired bacterial meningitis. In post-op neurosurgical patient, initiation of empirical antimicrobial therapy should be considered if CSF lactate concentration is more than mmol per ml. Then determination of the CRP concentration. Several acute phase reactors have been examined for their usefulness in diagnosis of acute bacterial meningitis. However, none is diagnostic for bacterial meningitis, and they should not be used to determine whether individual patients should receive antibacterial therapy. So CRP, which is made in the liver and secreted within 6 hours after acute inflammatory reaction that has been measured in patients with meningitis. The published meta-analysis has examined the utility of measurement of serum and CSF concentration of CRP to distinguish bacterial from the viral meningitis. Measurement of the serum concentration of CRP had sensitivity that ranged from 69% to 99% and specificity that ranged from 28 to 99%. In spite of these wide ranges and the odds ratio for serum CRP concentration, the diagnosis of bacterial meningitis was 150. The measurement of CRP concentration may be helpful in patients with CSF finding consistent with meningitis, but for whom gram stain results is negative and physician is considering withholding antimicrobial therapy. So on the basis of data showing the normal CRP has high predictive value in diagnosis of bacterial meningitis. Determination of the PCT concentration. Elevated serum concentration of polypeptide procalcitonin, which are observed in patients with severe bacterial infection, were shown to be useful in differentiating between bacterial and viral meningitis. In study of 59 consecutive children hospitalized for meningitis, the sensitivity of the measurement of serum PCT concentration for diagnosis of bacterial meningitis was 94% and specificity was 100%. In adults, serum concentration of 10.2 mg per ml had sensitivity and specificity up to 100% for diagnosis of bacterial meningitis, although false negative results have been reported by others. At present, because measurement of CRP concentration is not readily available in clinical lab, recommendation on its use cannot be made at this time. Then PCR. In patients who present with acute bacterial meningitis, an important diagnostic consideration is whether the patient has enteroviral meningitis. Rapid detection of enterovirus by PCR has emerged as valuable technique that may be useful in establishing the diagnosis of enteroviral meningitis. So enteroviral RT-PCR has been tested in clinical setting by numerous investigators and has been found to be more sensitive than viral culture for detection of enterovirus with sensitivity and specificity of 86 to 100% and 92 to 100% respectively. In addition, the time to identification of enterovirus using RT-PCR is significantly reduced compared with cell culture, which may lead to short-term patient hospitalization, decreased use of antimicrobial therapy for treatment of presumed bacterial meningitis, and reduced need of ancillary diagnostic tests. How quickly administered should be antibiotics should be administered? The longer the duration of symptom in patient with bacterial meningitis, more likely the possibility of experiencing adverse outcome. Although there is no definitive data to support this belief, the logical approach is to start administering antibiotics as soon as after diagnosis of bacterial meningitis is proven or suspected. So, what specific antimicrobial agent should be used in patients with suspected and proven bacterial meningitis? So once the diagnosis of bacterial meningitis is established by CSF analysis, antimicrobial therapy should be initiated. Empirical antimicrobial therapy is initiated either when lumbar puncture is delayed or for patient with purulent meningitis and negative CSF gram stain result. The choice of specific antimicrobial agent for targeted or empirical therapy is based on the current knowledge of antimicrobial susceptibility pattern of this pathogen. So recommendation for empirical antimicrobial therapy for purulent meningitis based on patient age and specific predisposing condition. If age of the patient is less than 1 month, then the probable organisms are Streptococcus agalacti, E. coli, Listeria monocytogen, and Klebsiella. Provisional antibiotics are ampicillin plus cefotaxime or ampicillin plus aminoglycoside. If the age is between 1 to 23 months, then the common bacterial pathogens are Streptococcus pneumoniae, Neisseria meningitis, Streptococcus agalacti, Haemophilus influenza, and E. coli. And the antimicrobials are vancomycin plus third generation cephalosporin. If age is between 2 years to 50 years, then bacterial pathogens are bacterial pathogens are Streptococcus pneumoniae, Neisseria meningitis, Listeria monocytogenes, and the aerobic gram-negative bacilli. And the antibiotics of choice is vancomycin plus ampicillin plus third generation cephalosporin. In case of hair trauma, basilar skull fracture, Streptococcus pneumoniae, H. influenza, group A beta hemolytic streptococci, and the antibiotics of choice are vancomycin plus third generation cephalosporin. Then in case of penetrating trauma, Staphylococcus aureus, cons, aerobic gram-negative bacilli, including Pseudomonas aeruginosa. Antibiotics are vancomycin plus cefepime, vancomycin plus ceftazidime, and vancomycin plus meropenem. In case of post surgery, the common organisms are aerobic gram-negative bacilli, including Pseudomonas aeruginosa, Staphylococcus aureus, Coagulous negative staphylococci, especially Staphylococcus epidermis. And the antibiotic of choice are vancomycin plus cefepime, vancomycin plus ceftazidime, or vancomycin plus meropenem. Then in case of CSF shunt, Coagulous negative staphylococci and Staphylococcus aureus and aerobic gram-negative bacilli like Pseudomonas aeruginosa and Propionibacter acti. And the antibiotic of choice are vancomycin plus cefepime, vancomycin plus ceftazidime, and vancomycin plus meropenem. What is the role of adjunctive dexamethasone therapy in patient with bacterial meningitis? Rationale behind DEXA use. The subarachnoid space inflammatory response during bacterial meningitis is major risk factor contributing to morbidity and mortality. So attenuation of this inflammatory response may be effective in decreasing many of the pathophysiological consequences of bacterial meningitis, like cerebral edema, increased intracranial pressure, altered cerebral blood flow, cerebral vasculitis, neuronal injury, as mediated by pro-inflammatory cytokine expression. So neonate. At present, there are insufficient data to make recommendation on the use of adjunctive dexamethasone in neonate with bacterial meningitis. About infant and children, the available evidence support the use of adjunctive dexamethasone in infant and children with H. influenza type B meningitis. So dexamethasone should be initiated 10 to 20 minutes prior to or at least concomitant with the antimicrobial dose at 0.5 mg per kg every 6 hours for 2 to 4 days. Then adjunctive dexamethasone should be given to infants and children who have already received antimicrobial therapy. Because administration of dexamethasone in these circumstances is unlikely to improve patient outcome. In infant and children with pneumococcal meningitis, there is controversy concerning the use of adjunctive dexamethasone therapy. Then in adults, on the basis of available evidence on the use of adjunctive dexamethasone, uh, it is recommended that the dexamethasone should be used in the dose of 0.15 mg per kg every 6 hours for 2 to 4 days, with first dose administered 10 to 20 minutes before or at least concomitant with first dose of antimicrobial therapy in adult with suspected or proven pneumococcal meningitis. Some experts would only add administered adjunctive dexamethasone if patient had moderate to severe disease. However, we think that adjunctive dexamethasone should be initiated in all adult patients with suspected or proven pneumococcal meningitis because assessment of the score may delay initiation of appropriate therapy. Dexamethasone should only be continued if CSF gram stain revealed gram-positive diplococci or if blood or CSF culture are positive for Streptococcus pneumoniae. Adjunctive dexamethasone should not be given to adult patients who have already received antimicrobial therapy because administration of dexamethasone in these circumstances is unlikely to improve patient outcome. The data is adequate to recommended adjunctive dexamethasone to adult patients with meningitis caused by other bacterial pathogen, although some authorities would initiate dexamethasone in all adults because etiology of meningitis is not always ascertained at initial evaluation. We recommended that adjunctive dexamethasone be administered to all patients with pneumococcal meningitis, even if isolated subsequently found to be highly resistant to penicillin and cephalosporin. Careful observation and follow-up are critical to determine whether dexamethasone is associated with adverse clinical outcome. Furthermore, in patients with suspected pneumococcal meningitis who receive adjunctive dexamethasone, addition of rifampin to empirical combination of vancomycin plus third generation cephalosporin may be reasonable pending culture results and in vitro susceptibility testing. Once bacterial etiology of meningitis is established, what specific antimicrobial agent should be used for the treatment? So first class is cephalosporin. The treatment of bacterial meningitis has been revolutionized by availability of third generation cephalosporin. In patients with H. influenza type B meningitis, the emergence of beta-lactamase producing strain and resistant to chloramphenicol has made this agent drug of choice for empirical therapy for H. influenza meningitis, pending results of in vitro susceptibility testing. In clinical trial, third generation cephalosporin have been found to be superior to chloramphenicol and cefuroxime and are recommended for treatment of childhood bacterial meningitis. In patients with pneumococcal and meningococcal meningitis, third generation cephalosporin are recommended in patients with meningitis caused by strain that are not susceptible to penicillin. Third generation cephalosporin are also quite effective in meningitis caused by aerobic gram-negative bacilli. For example, E. coli and Klebsiella. Cure rates of 78 and 94% have been reported, compared with mortality rate of 40%, 90% for the previous regimen that usually included with aminoglycoside with or without chloramphenicol. However, given the increasing frequency of antimicrobial resistance among gram-negative bacilli, especially in hospital setting, In vitro susceptibility testing of isolate is critical to guide antimicrobial therapy. One agent, ceftazidime, has also shown efficacy in several studies of patients with Pseudomonas meningitis. Fourth generation cephalosporin cefepime has been shown to be safe and therapeutic equivalent to cefotaxime in the treatment of bacterial meningitis in infant and children. Cefepime also has a greater in vitro activity than third generation cephalosporin against Enterobacter species and Pseudomonas aeruginosa and has been used successfully in some patients with meningitis caused by this bacteria, making it useful agent in treatment of the patient with bacterial meningitis. The next agent is vancomycin. The concomitant administration of dexamethasone with the subsequent decrease in inflammation and poor entry of vancomycin into CSF may have contributed to this negative outcome. On the basis of this finding, vancomycin is not recommended in treatment of bacterial meningitis caused by isolated that are susceptible to other agents like penicillin and cephalosporin. Even if the patient with meningitis caused by highly penicillin and cephalosporin resistant strain, vancomycin should be combined with third generation cephalosporin and should not be used as single positive agent. When used for treatment of bacterial meningitis, vancomycin should be administered to maintain serum vancomycin trough concentration of approximately 15 mg per. Intrathecal administration of vancomycin may be considered in patients who are not responding to parenteral administration. Now about rifampin. Rifampin has many properties that makes it excellent agent for treatment of meningitis, including good CSF penetration and in vitro activity against many meningeal pathogens. However, when used alone, resistance rapidly develops, such as rifampin may be used in combination with other antimicrobial agents. Clinical data on the efficacy of rifampin in patients with bacterial meningitis are lacking, but some authorities would use this agent in combination with third generation cephalosporin with or without vancomycin and in patients with pneumococcal meningitis caused by highly penicillin and cephalosporin resistant strain. Rifampin should only be added if organism is shown to be susceptible and there is a delay in expected clinical and biological response. Rifampin should be combined with vancomycin in patients with CSF shunt infection caused by staphylococci, especially in cases in which the shunt cannot be removed. Then carbapenem. Two carbapenem agents have been studied in patients with bacterial meningitis. That is meropenem, which has broad range in vitro activity and less seizure proclivity than imipenem. May be studied in both children and adults with bacterial meningitis. In this study, the meropenem has been shown to have clinical and microbiological outcome similar to those of cefotaxime and ceftriaxone and can be recommended as an alternative to this agent for treatment of bacterial meningitis. So meropenem has also been used successfully in isolated patients with pneumococcal meningitis caused by highly penicillin and cephalosporin resistant strain. However, the meropenem may be useful in patients with meningitis caused by gram-negative isolate that are resistant to standard therapy. So meningitis caused by gram-negative bacilli that produces extended spectrum beta-lactamase or those with hyperproduce beta-lactamase that is Enterobacter species, Citrobacter and Serratia marcis may best be treated with regimen that contains meropenem. Then the next agent is fluoroquinolone. The fluoroquinolone have been used successfully in some patients with meningitis due to gram-negative organisms. However, on the basis of limited published literature, these agents should only be utilized for meningitis caused by multidrug resistant gram-negative bacilli or when patients have not responded to or cannot receive standard antimicrobial therapy. The newer fluoroquinolone, that is Trofloxacin, getafloxacin, and moxifloxacin have enhanced in vitro activity against Streptococcus pneumoniae and have been studied in experimental animal model of pneumococcal meningitis. Trofloxacin was compared with ceftriaxone with or without vancomycin in multicenter randomized trial in children and in bacterial meningitis. Although truafloxacin is no longer utilized because of concern of liver toxicity, and these data suggest the potential usefulness of new fluoroquinolones in patients with bacterial meningitis. Pending results of ongoing trial, these agents should only be used as an alternative agent in patients with bacterial meningitis. Because these agents have not been studied in newborn and children with bacterial meningitis, they should only be considered in these patients who are not responding to standard therapy. In patients who develop bacterial meningitis after placement of CSF shunt, is it necessary to administer antimicrobial therapy by intraventricular route? The principle of antimicrobial therapy for CSF shunt infection are generally the same as those for treatment of acute bacterial meningitis. However, direct instillation of antimicrobial agent into ventricle through either external ventriculostomy or shunt reservoir is occasionally necessary in patients who have shunt infection that are difficult to eradicate or who cannot undergo surgical component of therapy. No antimicrobial agent has been approved by US Food and Drug Administration for intraventricular use, and the specific indications are not well defined. Antimicrobial dosage that have been used empirically, the dosage adjustment and dosing interval based on ability of the agent to achieve adequate CSF concentration. So after administration of first intraventricular dose, additional doses can be determined by calculation of inhibitory push. Prior to administration of next intraventricular dose, a sample of CSF is withdrawn to obtain trough CSF concentration. The inhibitory quotient is then determined by taking trough CSF concentration divided by the MIC of the agent for isolated bacterial pathogen. It should exist 10 to 20 for consistent CSF sterilization. Although not standardized, this approach is reasonable to ensure that adequate CSF concentration of specific antimicrobial agents are attained. In patients with CSF shunt who develop bacterial meningitis directly from shunt, does shunt need to be removed for optimal therapy or when can new shunt be implanted? Removal of all component of infected shunt and some component of external drainage in combination with appropriate antimicrobial therapy appear to be most effective treatment for CSF shunt infection. The ventriculitis of shunt infection appear to clear more rapidly with drainage catheter, and the presence of catheter allows continued treatment of hydrocephalus until infection has cleared. Success rates are lowered when the shunt is treated in situ because of the ability of many of these microorganisms to adhere to prosthesis and survive antimicrobial therapy. Timing of shunt reimplantation is dependent upon isolated microorganism and the extent of infection as defined by culture of samples obtained after externalization and occasionally on CSF finding. In patient with infection caused by cons and normal CSF finding, the presence of negative CSF culture results after externalization generally confirm the removal of hardware affected occur and patient can be reshunted on third day after removal. If CSF abnormalities are present and Coagulase negative staphylococci is isolated, 7 days antimicrobial therapy are recommended prior to reshunting as long as additional CSF culture results are negative and ventricular protein concentration is appropriate. If additional culture results are positive, antimicrobial therapy is continued until CSF culture remain negative for 10 consecutive days before new CSF shunt is placed.
For shunt infection caused by Staphylococcus aureus, 10 days of negative culture results are recommended prior to reshunting, and for gram-negative bacilli, 10 to 14 days course of antimicrobial therapy should be used, although longer duration may be needed depending on clinical response. Some experts also suggest that consideration be given to 3-day period of antimicrobial therapy to verify clearing of infection prior to shunt implantation. Although this approach is optional and it may not be necessary for all patients. What are indication of repeated lumbar puncture in patient with bacterial meningitis? In patients with bacterial meningitis who have responded appropriately to antimicrobial therapy, repeated CSF analysis to document CSF sterilization and improvement of CSF parameter is not routinely indicated. So repeated CSF analysis should be performed. However, for any patient who has not responded clinically after 48 hours of appropriate antimicrobial therapy. This is especially true for patients with pneumococcal meningitis caused by penicillin or cephalosporin resistant strain, especially for those who have also received adjunctive dexamethasone therapy. In neonate with meningitis due to gram-negative bacilli should undergo repeated lumbar puncture to document CSF sterilization because the duration of antimicrobial therapy is determined in part by the result. In patients with CSF shunt infection, the presence of drainage catheter after shunt removal allow for monitoring of CSF parameter to ensure that infection is responding to appropriate antimicrobial therapy and drainage. Now, what is the duration of antimicrobial therapy? In case of Neisseria meningitis, 7 days. In case of Haemophilus influenza, 7 days. In case of Streptococcus pneumoniae, 10 to 14 days. Streptococcus agalacti, 14 to 21 days. Aerobic gram-negative bacilli, 21 days. Diphtheria monocytogenes, more than or equal to 20 days. Now, what specific criteria should be used for outpatient antimicrobial therapy? Inpatient antimicrobial therapy, criteria for outpatient antimicrobial therapy in patient with bacterial meningitis. If patient has received inpatient antimicrobial therapy for more than 6 days, absence of fever for at least 24 to 48 hours prior to initiation of outpatient therapy, no significant neurological dysfunction, focal finding, or seizure activity, clinical stability or improving condition, ability to take fluid by mouth, access to home health nursing for antimicrobial administration, reliable intravenous line and infusion device, daily availability of the physician, establish plan for a physician visit, nurse visit, lab monitoring, and emergency, patient and family compliance with the program, safe environment with access to telephone, utilities, food, and refrigerator. Thank you, guys.